You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 29, 2024. We will be discussing the clinical management of urticaria and angioedema. This is presented by Dr. J. Portnoy, Professor of Pediatrics, and Dr. Pandya, an Assistant Professor of Pediatrics in the Division of Allergy, Immunology, Pulmonary, and Sleep Medicine at Children's Mercy Hospital.
All right. Thank you so much, Dr. Miller, for that kind introduction. And for everyone that's joining, thank you for joining all across the country. If your mic is currently on, if you wouldn't mind muting your mic, that would be much appreciated. All right. So today we are going to be talking about management of urticaria and angioedema. Again, I'm Arti Pandya. I'm an assistant professor here at Children's Mercy and at the University of Missouri, Kansas City. So let's go ahead and get started here. Dr. Portnoy may join during the presentation as well. There's no relevant disclosures from my end, and then from Dr. Portnoy, it's going to be a speaker for Thermo Fisher. So today our objectives are going to be being able to diagnose urticaria, developing a treatment plan for urticaria, and then determining etiologies for angioedema. As a reminder, this is a very brief overview of the of urticaria and angioedema. So a lot of the specifics with regards to different things relevant to those two disease processes or symptoms, you will see in subsequent lectures, but this is just meant to be a good overview, especially as you're starting out in your fellowship and evaluating patients with urticaria and angioedema. Here's a graphic pictorial making a play on the word hives here that we have. So there are going to be many different case scenarios that present for urticaria or rash in general. One interesting thing that always comes up is, the terminology that is used when describing urticaria. So firstly, families or patients will say, oh, I'm coming in with hives, or they'll say whelps or welts, something like that. So remember that in your mind, when you're kind of starting off with this evaluation, perhaps you just want to start off with a very general terminology of rash, and then you yourself determine whether the clinical pattern that you're hearing about fits urticaria or not. Here are some such scenarios that could be brought up. A 4-year-old developed an itchy rash 6 months ago. It lasted for a few days and then went away. 2 months ago, the rash came back, lasted a week. The patient ate a piece of pepperoni pizza in a few hours prior to the rash, and unfortunately avoided all pizza since. And then last week, the rash came back and lasted a few days, which led to this visit. And oftentimes, especially if there has been some food correlate or worry about some food that, the family may kind of anchor in that. But in general, when that happens, remembering for us, we take a step back and think about just the symptoms that they're describing alone. Like we don't anchor in what they are saying potentially could be the etiology. You, of course, take that into consideration if there is a strong temporal relation, but we'll kind of get into that in the talk a little bit further here. So that's one such case scenario. Another such case scenario that may come up is a 5-year-old who presents with a 3-day history of rash. The rash is worse in the afternoon, lasts for a few hours, and then goes away, not eaten any new foods, not changed any personal care products, and this is what the appearance of the rash may look like. And then one last case scenario, or actually there's 2 more case scenarios here. Oh, I apologize, this is a continuation of the previous one. A few days later, this individual develops swelling of the lips and eyes. Since the swelling affects the face, the individual is terrified it'll affect the airways as well. So we can see here that there is facial swelling and some potential periorbital swelling that we're seeing as well. So some things that we take into consideration when this is presenting is what is going on, what is the diagnosis here, what potentially could be causing this, is the patient at risk for laryngeal edema or not, and then one thing that may be in the back of your mind is, well, if it is an angioedema, what kind of angioedema is it, and hereditary angioedema may or may not come to your mind, and we'll delineate when it should and when it potentially shouldn't throughout this presentation today. And then the last question that may come to your mind is, should the patient be given an epinephrine autoinjector? All things that we're going to take into consideration. A last case scenario here, a patient who presents with a rash that's been present for several weeks. It's persistent, it does not move around or change over time. Discoloration of this rash can be present upon resolution. Cetirizine alone is suboptimally helpful. However, systemic steroids helped resolve the rash. Taking into consideration what could be the potential etiology here. Oh, and then, of course, especially here in summertime, definitely in Kansas City, maybe across the country as well, a girl here gets red raised, itchy, what they describe as welts every summer, lasts for several days. There's some scabs that develop, and it's very commonly happening when they're going outdoors. So there's a thought that there could be mosquitoes that are triggering this. And is she allergic to mosquitoes? And if she is, does she need to carry an epinephrine autoinjector? So let's start with the basics. Urticaria or hives. These are erythematous, raised skin lesions that are very pruritic. I say that, however, not all urticaria is always raised. There's atypical presentations where you could have more of a macular presentation as opposed to a papular presentation. Could also be in patches as well. The lesions can range in their size. So just because they're small or just because they're larger doesn't include or exclude the diagnosis of urticaria. So they can vary in size, and we kind of want to keep that into consideration. One very important thing is kind of the duration of these lesions. That's going to be very, very, very important for anyone evaluating urticaria, giving you a tip off as to whether this is urticaria or not. In general, these lesions will last for about 24 hours. In rare cases, they can last for up to 48 hours. In most cases, they're going to resolve before 24 hours. So that time duration is really going to help delineate whether your patient is having urticaria or whether we need to think beyond urticaria in terms of what they are having. In addition, sequela or consequences from the lesions. In general, so when we talk about some discoloration or scarring that can happen, with regards to urticaria, there could, if an individual is really scratching at the areas and irritating, the vessels right under the skin, there could be some mild discoloration. But in terms of stronger, like more purplish discoloration that's very dark in nature, in terms of any scarring, those sequelae generally do not happen with urticaria. And so taking that into consideration, again, is going to help very much so. And then lastly, urticarial lesions can affect any area of the body. If nothing else, just knowing these clinical features are going to be so important for all of us. The reason being is because we're going to see urticaria patients throughout our career many, many, many times. And it always comes back to understanding the basics. Is this hives or not? And how do I determine it's hives or not? It's going to be with my clinical evaluation. So asking the right questions. If there are pictures that the family has brought with you, making sure those pictures look consistent with urticaria. And if not, then not anchoring on just urticaria and potentially looking for other etiologies beyond that for what's going on for cutaneous lesions for your patient. So very important to remember these particular features with regards to urticaria. And then let's talk about angioedema. So angioedema is a type of edema. That's the first thing to remember. There's many different types of edema. There's lymphedema, etc., that can occur. So angioedema is one type of edema. It's swelling that occurs in the deeper dermis or subdermis. It can happen in various different areas. You can have your facial area involved, including the lips, eyelids, the genitalia could be involved as well. You could have extremities that are involved. You could have just the hands and feet that are involved. It can be itchy. It also can be painful. In terms of the nature of the pain and the reason for the pain, it is because your skin can stretch so much with regards to angioedema that it can be very uncomfortable for individuals who do develop angioedema. The resolution, so the resolution is actually going to be very variable. It can be within 24 hours, it can take up to a week or more. And knowing that difference is how we delineate what the etiology of angioedema is. So we're going to look, or we're going to discuss that here further in the presentation, is when you see a patient with angioedema, what kind of things do you think of right off the bat, and how do you determine, which branch of management and evaluation you need to go down in these individuals. In terms of angioedema, it's associated with urticaria in about 40% of cases. But one of the things I just remember so strongly, from my training as well as, even now practicing, is that as allergists, we assume that any swelling coming to us is going to be angioedema, but make sure you answer that first question. Is this actually angioedema or not? Is there some nature of blanching to the angioedema? And is it characteristic in terms of what's described here? The location, the time course, even the appearance. Does that meet angioedema kind of in terms of how it seems clinically or not? In terms of the prevalence of urticaria, it can affect between 15 to 23% of the population. And then again, 40% of patients with urticaria are also found to have angioedema. So it's highlighted here. So with urticaria, you can have a diagnosis that's either acute or chronic. And here we have the definition as 6 weeks. I've seen definitions of acute and chronic urticaria between 4, even down to 4 weeks. So kind of keep that in mind. In general, acute urticaria is going to be within that 4 to 6 week time window. And in 15 to 20% of cases, a cause can be identified. And then with regards to these individuals, when we think of common etiologies, we think of things that, could potentially have triggered it, including foods, exposure to medications, Hymenoptera venom exposure, latex exposure. Beyond that, even respiratory illnesses can cause urticaria. Other medicaments could cause urticaria as well. And so these are some things that we think about, but in reality, even acute urticaria, the majority of cases are idiopathic. So it's one thing to keep in mind is that while we do look for an etiology in acute urticaria, more often than not, it is an idiopathic process that occurs. And then chronic urticaria refers to when you've had lesions that are lasting for longer than 4 to 6 weeks, even 8 weeks. And here, in terms of an etiology, while there are certain types of chronic urticaria that can be associated with other disease processes, in most cases, this disease occurs in isolation. And so by the time that the patient is being evaluated by you, which is this point here, they're frustrated or they're feeling nervous about the fact that the symptoms have continued to last for this long. Their child or the individual may have impaired quality of life due to the nature of the disease, whether it be just purely appearance of the disease, constant pruritus, inability to sleep. And so they're looking for answers when they're coming into the clinic as to how to help. And so making sure that we are kind of aware of that when we're talking to patients and fully explaining chronic urticaria as a disease process, what is valuable in terms of evaluation and what is not valuable in terms of evaluation, and how we can treat those individuals. All of those things are going to be very important when we're evaluating our patients and treating them with chronic urticaria. And then for chronic urticaria, there's the correct terminology is going to be chronic spontaneous urticaria. With regards to chronic spontaneous urticaria, you could have a inducible phenotype or non-inducible phenotype. And so that's one other thing to kind of keep in mind when you're thinking about the disease process of chronic spontaneous urticaria. So what does inducible urticaria mean? We'll kind of see here on a subsequent slide. So inducible urticaria refers to when you have some component of your urticaria that's able to be physically induced. And so there's a lot of things that can do this. There's dermatographia, where just scratching of the skin can induce urticarial lesions. For this, there is actually a scratch test we can perform in the clinic where you take like a tongue depressor, like the blade, the area of that, and you just draw an X or something on the patient's back area. You wait about 5 to 10 minutes or up to 15 even to see if that is induced into an urticarial area or not. So that's dermatographia. There's delayed pressure urticaria, which can occur in various forms with stronger pressure or not. Between these two, also tight-fitting clothing. So like, say, for instance, if you're wearing like tight around the waistband area, or other types of tight clothing that could potentially induce urticaria in those individuals. Cold urticaria, so these exposures could be upon drinking a really cold beverage. You could develop some discomfort in your throat. Upon cold contact to the skin, you could get urticarial lesions, or sudden going into an environment that suddenly is cold. So whether that be jumping into a lake, being in an operating room, getting surgery and being administered IV fluids that are cold, all of those situations are where you could have cold urticaria develop. Aquagenic urticaria, we want to make sure that that's contrasted with cholinergic and cold urticaria. So it's not so much related to the temperature of the water as solar urticaria. You have to keep in mind, because solar urticaria, you may get a history that the patient went outside and they were also hot and sweaty. And so with regards to how you differentiate between cholinergic urticaria is in other settings where, you could have urticaria induced by cholinergic triggers, such as exercise, strong emotions, stress, hot showers. Those are all things that kind of help delineate whether, you're having cholinergic urticaria versus aquagenic or solar urticaria. And then vibratory urticaria and angioedema. So it can come up in various settings, but say, for instance, you're driving and you're holding a steering wheel that starts vibrating, you could actually develop urticaria and angioedema as a consequence. So keeping that in mind as well. So that's the classification of physical urticarias. We're going to talk a little bit further about urticarial vasculitis a little later in the presentation here. And here we have the distribution of urticaria according to age group. So this is largely up to 19 years of age in individuals. So with regards to younger individuals, the acute forms are definitely more common. Excuse me, and then recurrent and chronic kind of come up more as the individual is a little bit older. But that's not to say that chronic urticaria cannot occur in this age range. So keep that in mind. I have lots of patients who are kind of like in this age range who have developed chronic urticaria. So keep in mind that it's not a disease limited to being older. Okay, and so in terms of triggers for acute urticaria, especially in our younger patients, we know that viral infection is a very common cause of urticaria. And so, we kind of keep that in mind in terms of taking good history. If they've had some type of gastrointestinal infection, some type of infection with rhinitis, fever, etc., you want to take that in mind, take that into consideration, where viral infections are very, very common in terms of younger kids with inducing urticaria. And what's tricky is if they have bacterial infections, you can, of course, get urticaria as well. But then also if a medication is introduced, like an antibiotic, it can often get very confusing as to what actually caused the urticaria. Was it the infection alone that was going to cause urticaria, or was it the medication that you gave on top of it? Now, I mentioned antibiotics, but oftentimes for fever reduction, we also give ibuprofen, or NSAIDs, I should say, in general. So, which is a known cause of urticaria. So again, making sure that a really good history is taken can kind of help narrow some of these things down for us. So in terms of physical exam, if you have a patient who has urticarial lesions, great. If you're able to induce urticaria by doing a scratch test that's positive, that is great. But more often than not, in terms of the physical exam, by the time they see you, they may or may not, have active urticarial lesions. So that's where, again, the value of the history is so strong with individuals who have urticaria and angioedema. And I can't emphasize that enough. The value of the history in these patients is very important. And then keeping in mind that if you do have a patient where they have a positive scratch test, and if there's some other reason you're considering skin testing, the presumption here is that they developed urticaria to a blade of a tongue, the tongue depressor blade. And so they could develop urticaria with just a scratch or a prick from the actual skin test. So you can develop false positives. And so could there be more value in doing specific IgE testing? Again, if there's a reason that you're doing allergy testing or testing like that in these individuals. So in general, it is so important that we take a little bit of time in patients to talk to our patients who have had urticaria. The reason being is because by the time they come to you, like I mentioned, they're very frustrated, they have had impaired quality of life, and they're worried. So these are the things that I kind of lay out right at the beginning of my visit here, that urticaria in isolation, when there are not associated symptoms, is more often benign than not. And so again, when in terms of your evaluation for those patients, you want to make sure that you've evaluated for associated symptoms. And you want to make sure that that's evaluated in two different ways. I'm sure other ways too, but two ways just to kind of keep in mind as I'm doing this as kind of a beginner talk. The first is if they've had episodic urticaria, you want to evaluate for any other associated symptoms. Did they have vomiting? Did they have diarrhea? Did they have difficulty breathing, coughing, wheezing, etc.? Is there anything that's on the spectrum of anaphylaxis that occurred in individuals who have had urticaria? Let's assume not, and let's assume they just had urticaria. Are there any features to the urticaria that are atypical, or are there other changes in the patient's health that signal that something else could be going on, like an autoimmune disease or urticarial vasculitis? So those are two thought processes to have at the beginning. And if you're not picking up those and again, those features are largely going to be picked up when you're talking to the patient for the most part. So if you're not picking up those features when you're, taking a history here, then I think a good bit of reassurance can be given to your patients, and reassurance in a way that is not just, hey, you're fine, nothing is going on, but actually explaining what you're reassuring the patient about. So the specific things and this is, again, now kind of I'm giving my experience a little bit outside of this talk, but the specific things that families really respond to when I give a history is, one, if we're just talking about acute urticaria or chronic urticaria that's in isolation without anything else going on, that the individual is not at risk for systemic reactions in the future. Now, there are some exceptions to this, especially with some subtypes of chronic urticaria, so we'll talk about that a little bit later here in the talk. But if you're not seeing that, they want to know that, am I supposed to be carrying an epinephrine autoinjector? Am I supposed to be intervening with something more significant when my child or when I am having urticaria? So that's the first thing they want to know. The second thing they want to know, especially, any age range kind of wants to know this, is, does having either acute urticaria or chronic urticaria have some long-term consequence on my health? And so I kind of educate them about that. And then if they have acute urticaria, kind of discussing whether or not they're at risk for future urticaria happening, or if they have chronic urticaria, describing the nature of the disease, that a lot of the times this disease does self-resolve. I sometimes give them the statistics on, what time period it could resolve over. I do give them the caveat: for some individuals it could take longer, for some individuals it could take sooner. And then also giving them an idea of that this is a very treatable disease. So all of those things in general, in terms of my personal experience, I would say that when I say these important points here, about 60 to 70% of my patients kind of relax, and then they're more open to hearing what actually needs to be tested for and not. Because I think one of the things that we get frustrated as allergists is when there's a strong push from the patients to do specific testing to specific things. And we know that there's potentially not value here in doing a full food panel, but making sure that their concern is addressed prior to getting into that whole thing. Otherwise, if we're dismissing their concerns, they're hyper-focused on getting a test to figure out the one thing they need to avoid, because their belief is that one thing will kind of like help resolve the urticaria, which is not the case, right? And so that's kind of what important things that I utilize in my practice that could help really facilitate a good conversation with your patients. And then in terms of treatment, let's say, for instance, the presumption is here that you have chronic urticaria. You explain statistically that 50% of individuals are going to respond to just a FDA-approved dose of antihistamine. So let's say it's an adult patient, cetirizine 10 milligrams or fexofenadine 180 milligrams. And then I also kind of explain to them that that's 50% of people. If you don't fall in that 50%, then we could have to dose higher with regards to those antihistamines. And if it's somebody who's really struggled with their disease for a longer time, I kind of talk about as well, even sometimes in the first visit, that there's a whole different treatment. There's a whole possibility of different treatments that we have for things like chronic urticaria, even for acute urticaria too, but especially for chronic urticaria. So again, these things reassure your patient right off the bat. And so in my experience, it makes them more receptive to facilitating a better conversation and them not getting stuck in what they think will be helpful and realizing what will actually be helpful for them. In terms of monitoring disease severity, this is a very useful tool called the Urticaria Activity Score. So essentially what we do is we ask the patient these particular questions that can lead to calculation of an urticaria activity score. So it's going to be a score for actual urticarial lesions as well as a pruritus score. Both of these are kind of markers for disease activity. So you have a graded scale that you pick in terms of like numbers, and then you multiply it. If you're looking at this over 7 days, then you take this number and you multiply it by 7 essentially. So then you get an UAS 7 because it's over 7 days. And so that can give you some information in terms of what their disease severity is actually like. And then when you have the patient follow up, you get an idea of how well your treatment is working for that patient, whether you need to escalate, whether you're good to de-escalate treatment, etc. Oh yeah, and then let's see, I think here you can just have the different days listed off and kind of like write it all out. And you can give them like this sheet for them to do this at home. Or you can kind of give them ask them generally, hey, in your best opinion over the last 7 days, what do you think? How often, do you think we've had hives? How many hives? And how often have you had to hit itching and how bad, essentially? The minimally important difference for the UAS7 in patients with CSU is known to be 9.5 or 9.5 to 10.5 here. And so that's kind of listed out here. It speaks to the value of actually obtaining a UAS7 when your patient is presenting with chronic urticaria, and then keeping an eye on this score as you have subsequent visits with the patient as well. Again, it is a marker of disease severity. Okay, so I think I want to make sure I emphasize the point here about other disease processes, because we've gotten to the point of treatment for hives. So with regards to urticarial vasculitis, that was one point that I brought up earlier that I mentioned I would come back to. So this is not a talk that's kind of largely geared towards that particular disease, but there are some features that I would like to talk about here that are valuable to know. With regards to urticarial vasculitis, so this actually kind of came up, I think, in one of the initial case scenarios, where an individual was having urticarial-like lesions. So they look like potentially urticarial lesions, but they last longer than your 24 to 48 hour time window. Oftentimes, these individuals can have lesions that last even up to 7 days prior to resolution. And upon resolution, they can develop various degrees of discoloration depending on the skin type that they have, as well as potential scarring of the skin. And so for those individuals, we want to kind of make sure that we have delineated that from the history. And again, it just speaks to the point of the value of making sure you take a consistent history for urticaria every time you see your patient. So All right, so that now taken into consideration, how do we treat acute urticaria and chronic urticaria? For acute urticaria, largely your treatment is going to be limited to a short course of antihistamines, and then largely that's a self-resolving disease that doesn't necessarily kind of occur again and again for individuals. Let's say you have somebody with chronic urticaria. Our preferred treatment option is second generation H1 antihistamines. So two examples are listed here, cetirizine and fexofenadine, as very effective. In general, they're quite inexpensive. We can buy them in bulk, or if we get them over the counter, or different state insurances could potentially cover them as well. So relatively inexpensive. The dose can be up to 4 times the FDA approved dose if necessary. Keep in mind that side effects are going to limit it. Here we have sedation, but sedation is not the only side effect that can limit your dosing of cetirizine or fexofenadine. Particularly for cetirizine, you could also have constipation, dry mouth, dry eyes that develop. I've actually had patients who've had those side effects where we really, we needed to think about the next step of treatment because the dosing of the medication was quite limiting in terms of the side effects that they developed. Loratadine can work. Anecdotally, it's reported to be less effective. And then in general, first generation H1 agents are not recommended, and this includes diphenhydramine. Why do patients use diphenhydramine? It's the one that Benadryl, and as the trade name, in general is talked about the most, and in general has been, it came on the market earlier, it was advertised pretty heavily, so families know about it, and so they often reach for it. So the problem is that this medication is limited in terms of its duration of effects. It also has other components to it beyond antihistamines, adrenergic effect, alpha adrenergic effects. It can have cholinergic effects, etc. So it has other things that can cause other side effects. And then we've seen most recently here in studies where long-term use of this medication, which could be true if you have chronic urticaria, could be associated with other neurologic consequences like dementia in the future. And so in general, we don't recommend using that. The general recommendation is both in the European and in the US guidelines is to use second generation H1 antihistamines. What is the data behind H2 antihistamines? It's relatively weak. It's actually not even an agent in European guidelines, and I think even in US guidelines, that's part of the treatment algorithm. Can it anecdotally be helpful based on allergist experience? Potentially, yes. Is it potentially less expensive if it does work than going on to some of your more invasive treatments? Absolutely. So, you want to take an individualized approach with your patient in terms of what, where they are, in terms of knowing whether it could help or not, and in terms of where they are with regards to the next step for invasive treatment. So, or more, I shouldn't say invasive, I should say treatments that are higher risk that have more side effects associated with them. So that's kind of what I mean when I say that. So all of those things should be taken into consideration. So systemic steroids are an easy reach, especially if you are seeing a patient, like if a patient is seen in an urgent care or emergency department setting. The problem is we know that systemic steroids have long-term side effects for individuals, and we know that they have cumulative effects when they're given time after time, even in a single time year, like in a year's time period. And so in general, this is not recommended for individuals who have acute or chronic urticaria. Now, if you have urticarial vasculitis, that's a little bit different. But if you just have acute or chronic urticaria, this is not a treatment that's recommended. Doxepin. I personally have used this in my practice. So it's a tricyclic antidepressant, and it has H1 blocking effects. The problem is, so I think the second statement no longer holds true. Most health plans actually don't require this for the most part. I've actually not had a single health plan that came back to me and said, you didn't try Doxepin, therefore I will deny you a biologic therapy. So I think when this presentation was potentially originally made, that was the case. But again, it's not so much the case now. It is very sedating. And higher doses are often require more monitoring. So my personal practice has been not to use this medication as much. However, if you have a patient or let's say you have a patient who is very opposed to moving on to the next step in your treatment, which would be a biologic. So the treatment algorithm, the way it's outlined is you start first with FDA-approved dose of a second-generation H1 antihistamine. You quadruple up to that dose if it doesn't work. And then really after that, we start thinking about biologic therapy. So if for some reason even after you fully explained the risks, the benefits, if for some reason your patient is just very opposed to biologic therapy, that's where the value of talking about some of these other therapies lie. And that's also written out here on this next slide here. So these are all agents that have historically been used for chronic urticaria. And also down here, cyclosporin is still potentially a recommended agent. But in terms of these first three here, hydroxychloroquine, dapsone, and methotrexate, so between these three, hydroxychloroquine is probably the one with the best safety profile. You could have some side effects that we do need to monitor for, like ophthalmologic side effects, so keep an eye on that. And then with regards to dapsone, we do want to know if there's some risk or potential for developing G6PD-induced hemolytic anemia. Consider measuring that even before you initiate treatment. And then methotrexate carries lots of systemic side effects, but particularly liver toxicity. So cyclosporin is actually still part of our treatment algorithm if our patient fails biologic therapy with Omalizumab. So, and it is an agent that is very effective. However, you want to balance the nature of the treatment, the risks of the treatment, with regards to other potential treatment options that could help your patient. And so all of that should be taken into consideration. Just know that, cyclosporin, you have to appropriately educate on impaired kidney function, impaired liver function, potential risk for infections if you do use this as an agent. And so biologics for urticaria. The utility of Omalizumab for chronic urticaria has really changed, really revolutionized our ability to help patients with chronic urticaria. Because whether we like it or not, it's a disease that has a high degree of psychosocial implications for patients, high degree of impaired quality of life for patients. So really this treatment is, it changed the game, I should say, for chronic urticaria. And so it is, like I said, third in our treatment algorithm for chronic urticaria. It's very effective. We know that it's an agent that targets IgE, and it has pretty minimal side effects in terms of, it as an agent itself, and it's available both as a pre-filled syringe as well as now an auto-injector. The actual doses of the medicine include 75, 150, and 300. However, dosing for chronic urticaria is either 150 or 300, and it's currently approved at 12 years of age and above for chronic urticaria. It is a high cost medication, so oftentimes we need prior authorization or appeals or peer-to-peer. There are other biologics being studied. And then with regards to chronic urticaria, this is generally monthly dosing. Is there value in dosing more frequently? Potentially. If you have treatment failure at monthly dosing at your highest dose, which is 300 milligrams, there is some European data that suggests that increasing to 300 every 2 weeks could be more effective for patients. I have done that for patients, and I have had individuals who have had great treatment response as well. So that's one other thing we want to take into consideration. I think those are the major points here. Oh, and then in terms of actual side effects to look for, the major one that's kind of listed for Omalizumab is going to be anaphylactic reactions. Of course, the incidence are of that is actually pretty low. It's about 0.2%, but it's enough that, we do consider the first 2 to 3 injections being given in a ambulatory setting with a longer monitoring period for the first 2 injections, up to 2 hours. There are variable practices on whether we prescribe epinephrine autoinjectors for patients who are on omalizumab, so that's another thing to take into consideration. And then other side effects beyond that can include things like headache, pharyngitis, overall milder side effects. And then lastly, there are black box I don't think actually it may or may not still be a black box warning. So 2 things that have come up include cardiac side effects and then malignancy as a consequence of omalizumab, neither of which have substantial data backing those 2 side effects up. So, but your patients may ask about that, when they're looking into this medication. So appropriately counseling them would be important. Okay, so I think I've kind of touched on most of this, but we'll emphasize that one more time. So for somebody who's presenting with a rash with a question of hives, first confirm that the patient does, of course, have urticaria. Figure out if it's chronic or acute. Figure out if there's associated symptoms or not, and if there's anything additional to look into. Determine if testing is appropriate. So one second here, okay, good. So we have a following slide on the type of testing, so I'll get to that in just a second here. You do a trial of an FDA-approved dose of a second-generation H1 antihistamine. If that doesn't work, you can quadruple the dose, and if that doesn't work, then we consider the initiation of omalizumab. And if omalizumab doesn't work, we want to give this at least 6 months, if not even a little bit longer in certain cases. But if it doesn't work, then consideration of alternate treatments, specifically cyclosporin. So what tests have some value with regards to chronic urticaria and which don't? So if you're thinking about other systemic diseases, autoimmune diseases, a CBC indifferential, an ESR or CRP could be helpful here. If there's strong features concerning for an autoimmune disease itself, you can, of course, obtain an ANA with reflex testing. Just know that ANA has a lot of false positive testing, so there could be some limitations here. So with regards to extensive aeroallergen or food testing, this is generally not recommended. We know that food panels have significant consequences on patients, firstly. And secondly, if there has not been a clear temporal association with foods and development of urticaria, there's really no value here in obtaining food testing. The harms of obtaining food testing can include unnecessary avoidance of foods, nutritional issues, high cost of eating allergen-free foods, psychosocial implications, potential bullying, and then loss of tolerance of food if there is sensitization present in the absence of a clinical food allergy, which is more often the case than not with obtaining food panels. And then aeroallergen testing. Could this be helpful? Not as a whole test, because we know that the utility of therapy, such as immunotherapy, is very little in individuals who have chronic urticaria. That being said, are there aeroallergens that can induce induce urticaria in general? It's possible, yes. You could have certain grass exposures. You can have certain animal exposures like cat and dog, where you do get local urticaria upon exposure. So that part exists there, but that's not true necessarily of the majority of aeroallergens. And so you just kind of keep that in mind, that even if they're having hives that are induced by, let's say petting a cat or a dog, if they're having urticarial lesions that are outside of those settings as well, while you can obtain that testing, what are we going to do with the testing results is the real question here. And so anyway, that's something to take into consideration. I apologize here for this. So liver and kidney tests. So the reason we do these is to look for kind of associated disease processes. So we know that certain hepatic diseases, particularly infections, could induce urticaria itself. And then certain types of autoimmune diseases, including ones that have kidney involvement, could do it as well. So there could be some utility there. And then a chronic urticaria index panel. So this essentially measures an anti-Ig receptor antibodies that are associated with autoimmune urticaria. We know that with chronic urticaria in general, chronic spontaneous urticaria, you can have inducible disease and then non-inducible disease, and then autoimmune phenotypes, especially in individuals who have non-inducible disease. And so this test can have, elevated antibody levels. It doesn't necessarily alter your management for these individuals, but it is something that you could obtain. And if it is positive, let's say, meaning you do have elevated levels of the antibodies, just remembering that one autoimmune disease is associated with the development of other autoimmune diseases, which is the case as to why we obtain thyroid testing. So TSH, T4, as well as a free T4, of course, as well as thyroid antibodies. There's a lot of controversy on whether, so if you do have somebody who, let's say, comes back hypothyroid and then treat them, there's been different reports in our literature of whether treatment of hypothyroidism will result in resolution of urticaria. In general, cumulatively, the research kind of supports, or the literature, supports that treatment of thyroid disease does not necessarily result in resolution of your chronic urticaria. So keep that in mind. So a skin biopsy. So if you have features that are outside of the traditional chronic urticaria, you do really want to keep in mind whether they need a skin biopsy, especially if you're picking up features in your history that are consistent with urticarial vasculitis. So keep that in mind. Make sure if they have those features, you keep that in mind. And if you are able to perform the skin biopsy yourself, you perform it yourself. And if not, you involve your dermatologist. All right, so let's talk a little bit about angioedema here. So angioedema is subcutaneous or submucosal swelling from extravasation of fluid into interstitial tissues. As I was mentioning at the beginning of the presentation, it's not gravitationally dependent, and it's usually asymmetric and non-pitting. These are very important features, again, because it helps distinguish between whether your edema is angioedema or not. Your mechanisms for this disease can include a mast cell mediated process, also known as a quote-unquote histaminergic angioedema, or a bradykinin mediated angioedema. So how do you determine that with your history? Duration of symptoms, associated symptoms, can really help distinguish between those causes. So in general, bradykinin mediated angioedema takes longer to resolve. It can take 7 days to resolve a bradykinin mediated angioedema. And then in terms of associated symptoms, while in certain types of bradykinin-mediated angioedema, you can develop serpiginous rashes, in general, most of the time you don't develop associated symptoms. Now, one thing to keep in mind as I say that is the anatomical sites. So I'll get to that here in a second. The second thing is for mast cell-mediated angioedema, you can have associated pruritus and urticaria. So whereas you don't have associated pruritus and urticaria in bradykinin-mediated angioedema. Now, in terms of anatomic sites, this can include the larynx, lip, tongue, uvula, skin, mucous membrane, and bowel wall. So this is where I was kind of saying associated symptoms. Your presentation could be abdominal distension, pain, and that could be your tip-off that this patient is having bradykinin-mediated angioedema. And so that's an important thing to keep in mind when you're evaluating these patients. Again, I can't emphasize this enough, but clinical history is so important in angioedema as well as urticaria. Again, so bradykinin-mediated angioedema, we're going to hit on this here in a subsequent slide coming up, but you can either have this as a primary disease process, such as a hereditary cause, or it could be secondarily induced by something like a medication. The secondary angioedema is much more common than having hereditary angioedema. So especially, this can be for adult and pediatric patients. So for pediatric patients, making sure we don't assume that they're not on any chronic medicines and looking through their medication lists, and definitely for adult patients, making sure you do a full comb through of their medication lists. And then NSAIDs, estrogens as well could be involved here. So with regards to hereditary angioedema in general, so we know that this disease, while the name implies hereditary, there could be some family history of this, or there could be a new mutation that a patient develops where they develop hereditary angioedema, where it's not quite hereditary to them, but now it's a new mutation where they've developed this particular disease process. I think I talked about this, it's not associated. So this is a type of bradykinin mediated angioedema. So it's not going to be associated with hives. There's usually a family history, but again, don't use that as an exclusion criteria necessarily. And then episodes usually don't start before puberty, although, in general, pediatric presentation is common, but you can have later onset presentations. And then in general, episodes, like I mentioned, it can last pretty long prior to resolution. Antihistamines and epinephrine do not help. C4 can be used for screening, helpful particularly during an episode, and then you can develop functional and actual quantitative and then functional testing for HAE. So we're going to see that here in a subsequent slide. So this is for hereditary angioedema, not to be confused with acquired angioedema, which is different from medication, and like a secondary angioedema that could be medication induced. So let's see, we have a slide here that helps delineate all of those things. So for hereditary angioedema, we have HAE type 1, which has decreased levels of the concentration as well as function, and then C4. And then we have HAE type 2, which can have, normal level of function, normal level of concentrations of C1 esterase or C1 esterase inhibitor, but decreased function, and then as a result, decreased C4. And then in terms of that, delineating that between acquired angioedema. So acquired angioedema can occur in various different states, such as autoimmune diseases, vasculitis, cryoglobulinemias. Here, we're going to see a low C4, C1 esterase level, C1 esterase function, as well as C1q. And then we delineate that with, let's say, ACE inhibitor-induced angioedema, where we see no such lab abnormalities, and then idiopathic angioedema or other drug-induced angioedema. Okay, let's get to our summary here. Most urticaria is idiopathic. Urticaria can be spontaneous or inducible. One last point I was going to get back to here, which is cold urticaria. So this is the exception in terms of subtypes of physical urticarias that it could actually have a risk of a systemic reaction. So these individuals are at risk for systemic reactions. There's ice cube tests that we can perform. Again, I didn't get into all of the specifics of that because you all are gonna have a subsequent talk on chronic urticaria where we do get into the details of that. And if you have a positive ice cube test and if the history fits cold urticaria, there is a recommendation to carry an epinephrine auto-injector, and then special precautions should be given to them. Warmed IV fluids if they're getting procedures. If they're jumping into a lake, we recommend slow submersion as opposed to just jumping into a cool body of water. History is so important on nature of the lesions, duration, post-resolution hyperpigmentation or scarring, and then inquiring about general changes of health to determine if autoimmunity or malignancy needs to be evaluated. Testing should be done based on clinical history. Let's say there's concern for vasculitis, autoimmunity, etc. Treatment is recommended initially with second generation